Semoga acara hari ini dapat membawakan knowledge baru di dunia neonatology.
Selamat pagi. Yeah, I think that's the only bahasa that I do know. Yeah, so today I will be talking about FOT, so forced oscillation technique. So this is something that is non-invasive that actually can help you to assess your lung mechanics at bedside. Okay, so today we'll talk about what is FOT, what is the basic theory and also principles, and then how we use FOT on the Fabian ventilator, and then bedside applications, and also as well as clinical examples. So I think just now all the previous topics we did talk about using volume guarantee, using low tidal volume for the patient to try to avoid lung over distension. And then also as well as I think with Dr. Adi, we did talk about using the most appropriate PEEP to avoid lung tissue over distension, and also try to optimize lung recruitment for the patients. So what we want to do for our RDS patients is to individualize our protective ventilation by selecting the correct tidal volume for them, and also the right level of PEEP for them. Okay, because each patient is different, so you might want to set a different tidal volume for each patient, as well as setting other like the PEEP for them, the correct PEEP for them. Okay, so this one I think the mask. So this one I think Dr. Adi also showed this diagram before. In his slides. Okay, so we have patients who are going through recruitment maneuvers where we increase their pressures accordingly. So yeah, hello. Yeah, so the pressures we increase from like 0 to 4. You can see that during inflation phase, the lung remains collapsed the whole time until you increase the pressures to 16. Then you see that the lung starts to get inflated. Okay, but then during deflation, you realize that the lungs actually stay open for a longer period of time, because once we use the correct pressures to open up the lungs stays inflated. Yeah, so for this, right, usually for us, we want to make sure that we set the pressures to make sure that we do not have atelectasis lung collapse, which is this part here. But then at the same time, we do not want to give too much pressures at this level here where we actually cause over distension. So we want to set the correct pressures so that we ventilate the patients at the safe window, which is this area here, so that we do not cause injuries to the patient where there is atelectasis and over distension. And when we have atelectasis and over distension, most of the time when we do this, what happens is that we will tend to give too much FiO to the patient, and this might be detrimental. And so how do we optimize ventilation parameters is that you will see that a lot of times you will do CT scans, but it's not very feasible to keep transporting the patients down for CT scans to look at the lung conditions. So a lot of times we depend on what we have on the bedside, which is oxygenation, like looking at the SpO2 readings or your arterial blood gases. Yeah, these are very powerful numbers and tools that we can use at bedside. Yeah, which I think we discussed also in the first lecture about ABGs, how do we troubleshoot, and based on that. And then, but the problem with this is that with oxygenation, it has a lot of other things that actually affects the oxygenation. Maybe the patient's perfusion and all these other factors that will actually affect the oxygenation. So another tool that we can see on how to optimize patient's ventilation is to look at the patient's lung mechanics, which is, you will see that here we can take a look at the patient's compliance. So you see that this is a pressure volume curve. We can actually look at the patient's PV loop here to actually find out what's the compliance, and then from there we can find out the atelectasis and also over distension. So challenges that we faced in ICU, like we said, there is very limited tools that we can use at bedside to measure patients optimize ventilation, and also whenever patients have spontaneous activity, it's also difficult for us to make any to find out what is their lung mechanics also as well. Okay. So here on our Fabian ventilator, we have this thing called forced oscillation technique, FOT. So it's a very simple to use tool and minimally invasive that can be used to study the mechanical properties of the respiratory system of the patient by applying an external force signal. So it's like giving a sound signal to the patient or oscillation signal to the patient, and then it will assess the patient's lung compliance, okay, lung mechanics, lung compliance, and then from there you see that how much pressures you are giving to the patient will have what effect on the compliance, okay. So this mechanical response is what we call impedance, okay. So here you will see that it's like a ventilator here is sending out a small oscillatory pressure, okay, signal to the lungs. And then we will have a mechanical response from the lungs, and it will be signaled back to the ventilator itself, okay. So this signal that is going back that has a mechanical response is what we call the impedance. Okay, so this is a bit physics, but impedance has two components, the resistance and also the reactance. So resistance is what we know on the ventilator compliance and resistance, right? Yeah, then reactance is something that is what we call imaginary part, okay? So based on what we have found out, actually the reactance is actually directly proportional to our compliance. Okay, so this is the equation here. So this is reactance, and then we have the compliance here. So it's actually directly proportional. So which means that the better reactance that we see on the ventilator when we send the FOT signal, the better the compliance. Okay, so here you will see that on the graph here, when we send the oscillatory compliance to the patient, when the compliance increases, your reactance also increases as well. So when you do a FOT, you get a similar PV loop curve as what you have done as a recruitment maneuver itself. Yeah. So you will see that when there's de-recruitment, your oscillatory compliance, your reactance will be low. And then after that, when you have optimal PEEP, your compliance and reactance will be high. And then when you give too much pressures, again, it will go to over-distension here. Okay, so this is how we can see on FOT how the compliance changes when you change the pressures for the patient. So with FOT, right, we can use it in two modes, in HFO as well as conventional ventilation. So with HFO, we are able to find different compliance at different pressure levels and we'll be able to find the optimal mean airway pressure as well as the optimal PEEP to set for your patient in conventional ventilation. So so this is the FOT graph that you will see. Later on, we'll discuss more about it, okay? So FOT, what signal do we send out? We send out about 5 cm water at 10 Hz to the patient's lungs. And then from there, we will record the pressure and flow signals back to the ventilator itself to find out what is the reactance. And then from there, we know the compliance. Okay, so there is two types of FOT on our Fabian HFO. There is the FOT HFO, which the forced oscillation comes from our HFO module. So the mode of ventilation measurement will not change because this mode is done only in HFO itself. Then also we have the FOT conventional. So the oscillation is from the exhalation membrane, and then during which the mode is changed to CPAP when we are doing the FOT. Okay, but it's only for a very short period of time. So we have two types of FOT, FOT conventional for your conventional modes, and then FOT HFO for HFO modes. Okay. So this is how you will see on usually when we do the FOT procedure. So we can increase, now you can see that we increase from this low pressure here to the high pressure of 25. And then at each step where we increase the pressure, you will see that we increase the mean airway pressure up. We actually measure the reactance, which is the compliance at each level. Okay, so you will see that at this point here, it actually goes to over distension, and then after which we go to the deflation limb where we go backwards. You will see that the compliance is much better, and then now when it goes down here, it's like this actually de-recruiting very fast. So we will see that here at level 10, okay, this part is where we have the optimal mean airway pressure that we can set for the patient. So this is a very non-invasive tool. You just need to press start, and then you go to each mean airway pressure level, and then the ventilator will do the plotting of the graph for you. Okay, but at the same time, you will need to monitor your patient also as well, because whenever we increase the mean airway pressures to high levels, of course, there's hemodynamical change and everything. So of course, we need to monitor the patients at the same time. So this is how the screen looks like on the ventilator, where we can set the FOT for the patient. So you will see that here we have the FOT number of steps. Then this is the mean airway pressure low, and then mean airway pressure high. So it's showing here that we will go from mean airway pressure of 5, increase up to 10, and then increase up to 15, and then up to 20. And then it will go back down from 20 to 15 to 10, and then to 5. Okay, so you can see that the number of steps here is 7. So it will go like 1, 2, 3, 4, 5, 6, 7. Okay, each step here is 5. So depending on how you do your recruitment maneuver, maybe you do not want to increase it so fast by increments of 5. You can make it smaller also as well, the smaller increments. Okay. So here you will see that this is a smaller increment where we are increasing from 5 mean airway pressure of 5 to 14 in 7 steps. Okay, so here you will see that first it will be normal ventilation before recruitment, and then after that we actually put the pressure, mean airway pressure, down to 5. Okay, to give the pressure to the patient, and then here number 1 here we are giving FOT signal. Okay, for a few seconds to measure the patient's compliance. And then after that, we have some normal ventilation before we increase back up to 7 for the patient for the FOT, to measure the FOT, to measure 7 of mean airway pressure. And then after that, we give the FOT signal. And then after that, we will increase up to 9 and up to a level of 14 here. Then from 14, it will go back down again to mean airway pressure of 5 again. So in between, you will see that we are giving FOT for the patient. And then from here, you will see that it will come out as a loop here again on the ventilator itself for you to see what is the best mean airway pressure for the patient. So from the loop, can someone maybe share what do you think is the best mean airway pressure for the patient based on this FOT loop? I think maybe around 15 or 20. So depending on which one is higher, right? Okay. So yeah, so you can see that this one is actually the compliance. So you can see that here at 20, okay, if we can do a bit more to 25, we see whether it goes down or not. Okay, but otherwise maybe we can set the optimal mean airway pressure for the patient at 20. Okay, yeah. So later on we'll have another question, then I think maybe we can give out teddy bears. Okay, so here fastest, who knows what is the most optimal mean airway pressure for this? Okay, 10? Yeah, okay. So 10 would then be the optimal mean airway pressure. So again, we are increasing the pressures from 0 to 25. And then at each pressure level, the ventilator is giving a FOT signal. So then it's plotting the graph for you. And then you can see that over this here, the compliance actually decreased after 15. So we will see that there is the zone of overdistension. So we are giving too much pressures at 25 and 20 for the patient. And then as we back it out, you will see that the compliance is actually much better now because we managed to recruit the patient's lungs and open it up. And then here would then that you see that at the best mean airway pressure would then be at 10, where we have the best compliance. And after which, once we go down below this point, the patient's lungs quickly de-recruit and we lose the compliance for this. Okay? And then here is another example that we can see that how we can use FOT in our daily clinical life is that you see that there is this patient that we give, before we give steroids to the patients. So you can see that there is some dots that you can see that the patient's lungs is actually recruitable before that. So as we increase the pressures for the patient, the PEEP for the patient, you can see that now it goes to overdistension. We manage to open up the patient's lungs. And then as we back it up, here, if we want to set, we can set the optimal PEEP here at how much? 12, right? Yeah, so this is where we get the best compliance. Then after which, right, you can see that after they actually give steroids to the patients and the patient's lungs improve better. So after the recruitment, you can see that it actually opens up the patient's lungs already. And then we are able to actually use lower PEEP for the patient to completely open up the patient's lungs before it goes to overdistension. So you can see that for this graph here, what do you think is the best PEEP that we can set for the patient? 8, right? Yeah. So just now, the best PEEP before recruitment and also before steroids is 12. And then after we give steroids and do some recruitment for them, the best PEEP that we can set for the patient is now 8. Okay, so all this, right, is actually very simple. You just need to use it on the ventilator itself. Just go do the recruitment maneuver, set the settings that you want, and then you will be able to easily see what is the best mean airway pressure that you want to set for the patient, or best PEEP that you want to set for the patient. Okay. So here, just now, I think we went ahead a bit. This is the where we can see that instead of setting the mean airway pressure, we are setting the PEEP for the patient in conventional ventilation. So instead of finding the optimal mean airway pressure, we are finding the optimal PEEP. So the layout is exactly the same, just that these two values, instead of mean airway pressure, it becomes PEEP when you are on conventional ventilation. So again, this is an example where they increase the FOT steps from 4 to 10 in 7 steps. So it will go 4, 6, 8, 10. And then from 10, 8, 6, it will go back to 4 for the patient. So here they go down to the PEEP of 4 and send a FOT signal. And then go to PEEP of 6, FOT signal. PEEP of 8, FOT signal. PEEP of 10, maximum, because this is the PEEP high that you set. Then you send an FOT signal and then go back down to 8, another FOT signal, 6 FOT signal, 4 FOT signal. So that's how they come up with this whole loop here, which end up you, after doing this whole 7 steps, you will see that this will be the loop that you will get to see on the ventilator. So again, what do you think is the best PEEP that we can set for the patient? 8 and 10, yeah. So this one like very close fight, right? So maybe if it's a close fight, then maybe we will need to increase the PEEP high to slightly higher to 12, and then we see whether it goes down or not. Yeah. So maybe from there we can, because if it looks very close by, which is the same for just now the example also, because it looks very close. So if it looks very close, maybe you can increase it to higher and see whether how the curve looks like for higher pressures. Okay. Yeah. So some tips when you are using FOT is that make sure that the patient's conditions of the lung is not changed. Okay, so so like just now we said, we do lung recruitment maneuvers, definitely the lung condition will change. So you will need to do another maneuver here and then see what is the best PEEP to set for the patient. Or after you give surfactant or steroids, then maybe you will need to do the maneuver again to find the optimal mean airway pressure or optimal PEEP. And then also if there is obstruction of the tube, so there's a lot of secretions going on, so make sure that you suction the patient's lungs first before you do the recruitment, this FOT procedure. Okay, also one more thing, if the patient is having fast inspiration, it may corrupt your readings as well. So maybe you will need to repeat the FOT signal sent to the patient to make sure that the results are reproducible. Yeah. And also if there is a lot of leaks or disconnection that's happening throughout the FOT procedure, you might need to restart the whole procedure again. Okay, I mean the machine will also restart for you when you are doing the FOT signal, because they will tell you that there is too much leak. It's not, the results will not be accurate. Okay, and then of course FOT will measure the patient's lung condition at the current ventilator settings. So if you were to change the ventilator settings of the patient, like a tire volume or respiratory rate or other parameters that you have set for the patient, then of course the optimal PEEP for the patient will change accordingly as well. So after, if you change any ventilator settings, it's better for you to repeat the PEEP trial again. Okay, so here are some clinical papers to show the use of FOT. So this is just to talk about FOT that is used and its correlation to the CT scans that you have. Okay, so the conclusion for this is that FOT measurements with the reactance level actually is a very useful non-invasive bedside tool for PEEP titration. So whatever that we have measured for the reactance, actually it correlates to the CT scan that they have set, that they have done for the patient. So you do not need to keep sending the patient down for scans or doing chest X-rays for them. Yeah, so we are able to actually minimize the X-ray exposure for the babies. So maybe like, can I ask, like maybe in a baby's 3-day stay in the ICU, how many X-rays do you usually give? Do you take for them? If the baby is a very preterm baby. Depends on the baby. Depends on the disease. Maybe if it's RDS, 28-weeker, 2, 3. 3 days, 3. So every day you'll take one. Something like that. Or like if there's condition change, you will also take. If there's, yeah, correct. So whenever there is a bad desaturation, you also take one. Yeah, then after that, if there is some things that went wrong, you also take, right? So, I mean, depends on how stable the baby is also, correct? So the more unstable the baby is, the more X-rays you give to them, correct? Yeah, to look for the babies. So for this, maybe if we have the FOT here, instead of doing X-ray for them, yeah, maybe we can also see, we can also do FOT to actually take a look at how the patient lung compliance is changing also as well. Yeah, not to say that FOT will replace entirely X-rays. Yeah, but to say that maybe we can use it when maybe it's just a normal transient desaturation. If you want to see what's happening, you can actually do a FOT results for the patient. Okay. Here also another study that we do have here is actually talking same thing about adjusting of PEEP by FOT, that actually we are able to use a higher PEEP for the patient when we are on FOT, and then we are able to do lung protective ventilation for the babies. Yeah, because for your extremely preterm infants, their lungs are easily over distended even at low PEEP. So especially after you give them surfactant. So that's why with FOT, right, we are able to actually set a better PEEP for them to prevent over distension after we give them surfactants. So we are able to better protect their lungs. Yeah. So same thing here is also talking about how we can use FOT to actually reduce ventilator-induced lung injury. So they are comparing some studies that we use with ARDS net, that we set a fixed PEEP for patients, and then we use FOT. Okay, so with FOT we are actually able to set a better PEEP for the patient as compared to a PEEP number that comes out from a table that is that might not be personalized based on the patient's disease. Okay, so this is another case report that they use it for a patient on ECMO. So for this patient, right, actually the patient is on ECMO, and then they started FOT for the patient on day 6. So on day 6 onwards, right, you can see that the compliance is still not very good. But then they started giving surfactant for the patient from day 9 onwards. They started giving the surfactant for the babies. And then they realized that the patient's lungs on FOT actually improved. But then on chest X-ray, it didn't show any improvements. So, but then they decided that they should start weaning the patient off. And then from there, from day 9 onwards, they wean the patient, and then they are able to actually extubate the patient from there. So sometimes, like this study, I mean, it's just a case study, but it's saying that maybe you can actually use FOT to try to wean your patients. So once you see that the patient's compliance on FOT has improved, then maybe you can start weaning the patient already. Okay. Then also this one is another case study that we talk they are talking about how the patient's response to bronchodilator, okay, with a patient that is evolving BPD. So you can see that here is a patient 1 and here's patient 2. You can see that the patient's 1, this is pre-bronchodilator, and then here is post, black color would then be post-bronchodilator. So for patient 1, right, you can see that pre-bronchodilator, they can look at the we look at the compliance actually improved. Post-bronchodilator, the compliance improved, okay, whereas and also the reactance also improve, resistance also improve also as well. So you can see that patient 1 is a responder to bronchodilator, as compared to now we see that here is a patient 2, where pre and post bronchodilator, right, the reactance, resistance and also compliance remains the same. Yeah. So not just only when we are doing recruitment maneuvers, we can do FOT, but also to assess patients' response to therapy like bronchodilators or steroids. You can also use FOT to see whether the patient is a responder or not. So as a summary, FOT is something that is very non-invasive, okay, and does not require your patient cooperation. You can do it anytime on the ventilator itself. So later on during hands-on, maybe you can take a look at how the FOT is being done. And then maybe next time when you are using Fabian ventilators, you can try it out on your patients. So it's something that is non-invasive, so you do not need any additional equipment to do that. Yeah, and then also even though the patient is having spontaneous breathing, okay, it still allows us to monitor the patient's lung compliance and conditions, okay, at the volumes that we do have. And also is easy to use, especially it's just available on the ventilator itself. You do not need additional equipment. Yeah, that's all. Yeah, I think Dr. Adi, you want to do summary?
Thank you, Mr. Hui. Very nice explanation. Now allow me to translate it in bahasa as a summary. Kayaknya ini yang ditunggu-tunggu ya. Biasanya gitu. Ya, jadi force oscillating technique ini adalah sebuah terobosan baru ya di dunia ventilasi mekanis. Yang alhamdulillah udah ada di ventilator Fabian. Cuma ventilator ini ya, nggak ada di ventilator yang lain. Jadi punya khas dia. Saya bukannya promosi, tapi emang khas Fabian. Jadi sistem kerjanya adalah dia bisa membaca kondisi paru itu bagaimana sih, compliance-nya yang tadi tuh yang gambar pegas yang saya jadi udah mengembang, udah gampang belum mengembangnya atau tidak, caranya gimana? Caranya dia akan memberikan sedikit getaran ya, seperti HFO gitu, getaran, getarannya kira-kira berlangsung berapa second, masuk ke saluran pernafasnya, ke paru-parunya. Nanti dari getaran itu kan ada udara yang masuk ya, seperti HFO ada udara yang masuk, dia bisa mengukur tuh berapa sih energi yang hilang menuju paru-paru tersebut. Nah, energi yang hilang itu bisa dua komponen tadi dia bilang, bisa resisten atau reaktan. Nah, reaktan ini sesuai dengan sebanding dengan compliance. Jadi dengan melihat reaktansnya berapa, nanti kita bisa melihat seberapa ngembang parunya. Jadi kita bisa memilih nih sekarang, kita punya pilihan berapa sih mean airway pressure yang kita pasang kalau pakai HFO, kalau pakai ventilator konvensional, berapa sih PEP yang kita tetapkan. Kenapa? Karena PEP adalah komponen utama dari mean airway pressure. Ya gitu. Nah, tadi Miss Hui, coba slide-nya gambar. Maybe I need your slide about which point in the reactant should we choose? That's it. That's one. Oke. Ya. Jadi ini adalah kurvanya. Begitu kita tinggal set aja, tapi setnya peningkatannya angkanya ganjil. Bisa 7 kali, berapa kali naik? 7 kali, 9 kali, 11 kali, nggak boleh genap. Kalau genap nanti nggak ada titik ujungnya. Sudah gitu kita bisa set berapa lama dia dikasih getarannya tersebut, dan nanti outcome-nya akan terlihat kurva seperti ini. Di sini kita kurvanya namanya reaktan. Jadi beda sama kurva PV loop ya, yang tadi kita perlihatkan sama-sama. Kalau kurva PV loop kan kita ambil yang paling pojok sebelah sini ya, pojok atas sebelah kiri. Nah, tapi kalau dia ngambilnya yang paling tinggi. Kenapa? Karena dia ngambil reaktan yang paling baik, artinya mengambil compliance yang paling bagus dengan mean airway pressure demikian yang kita harapkan gitu. Jadi kalau pada kasus ini nanti di set, nanti ada workshopnya ya. Di set berapa nih? Berapa kali? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Ini 11 kali dia naiknya. 11 kali. Nah, nanti setelah 11 kali otomatis berapa lama periodenya 11 itu nanti kita set. Nanti otomatis dia akan ngitung sendiri. Nanti udah selesai, nanti beberapa menit nanti kelihatan di layar. Jadi ini, terus naik ini, naik ini, naik ini, naik ini, naik ini, dan sebagainya. Akhirnya jadi ketemu kurva reaktan seperti ini. Ambillah reaktan yang paling bagus di atas. Jadi seperti itu. Yes. Ya.
Gitu.
Iya,
waktu kita,
seperti manual yang tadi kita
manual itu ya ditungguin, kemudian karena memang MAP kan komponen indirect untuk oksigenasi ya kita lihat dari SPO2-nya gitu loh. Jadi seberapa sensitif sih dok kalau kita nggak punya pulmonary reactance graph ini, terus kita sambil ngelihat saturasinya, karena walaupun memang saturasi kan output akhir banyak hal yang mempengaruhi gitu ya dok ya, tapi karena kita nggak punya ini si grafik ini, nah seberapa sensitif si SPO2 ini dengan kita sambil ngatur MAP-nya gitu dok?
Ya masalahnya ya tadi Dr. Mahendra menanyakan kalau kita nggak punya reaktan kita pakai saturasi oksigen untuk memperlihatkan derajat pengembangan paru seberapa sensitif. Pada kasus yang non hipertensi pulmoner ya, artinya kalau FeO2 itu nggak ada hipertensi pulmoner, itu menurut saya sangat sensitif. Jadi korelasinya lurus antara mean airway pressure dengan oksigenasi. Cuman kalau ada kelainan jantung bawaan, ada shunting kanan ke kiri, itu akan nggak berbanding lurus lagi gitu. Jadi hati-hati ngelihat saturasi kalau dia ada kelainan jantung bawaan atau hipertensi pulmoner. Dia nggak bakal kita naikin, nggak bakal korelasi dia lurus gitu. Iya. Makasih dok. Jadi kita kesini lagi ya. Jadi teman-teman ambilnya yang paling tinggi. Coba slide, another slide, Miss Hui, maybe another graph like this. Nah, this one. Nah, kalau before, this is good. Miss Hui, I think they should choose this one, right? Or oh, yeah, yeah, yeah. Baik. Dan pada kasus ini, kan kita lihat nih reaktan paling tinggi ini, tapi kita nggak ketemu over distensinya. Ya, kan nggak ada over distensi ya. Harusnya kalau kita mungkin kita harus tambahkan lagi stepnya, mungkin nggak 1, 2, 3, 4, 5, 6, 7. Ini ada 7 nih, ini berdempet. Ada 7, mungkin stepnya harus ke 9. Yang ke 8 ke 9 ya. 9 atau 11. Nanti ini grafiknya kan kelihatan nukik ke bawah. Kalau nukik ke bawah itu tandanya over distensi. Kita jadi ambil yang ini. Kalau dia kalau enggak ya terus lagi yang paling atas lagi yang tinggi terus sampai ketemu gambar nukik. Nah, seringkali yang saya kerjakan pada FOT ini pasiennya udah ngembang. Nanti dapatnya enggak kurva seperti ini, kurvanya langsung turun ke bawah. Jadi sebenarnya parunya sudah mengembang gitu. Maybe another graph yang the one this I think. Nah, dia harus seperti ini, paling bagus tuh paru-parunya kolap. Kalau parunya kolaps kita mulai itu kita akan kalau lakukan FOT 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, mungkin 13. 11 mungkin ya, karena ada yang berdempet. Nah, ini kelihatan di sini nih turun ke sini. Berarti kita ambil yang atas ini. Nanti kalau rekan-rekan mulai gambarnya langsung turun ke bawah itu artinya udah ngembang ya, nggak usah ambilnya yang paling pojok, yang paling tinggi gitu. Beda sama kurva PV loop ya. I think it's all. Okay. There's a question. Okay.
Nggak apa-apa, pakai Indonesia aja ya dok
Okay.
ya. Nggak apa. Selain pertanyaan yang tadi di belakang, pertama pertanyaan tadi Dr. Adi tentang X3 disertasi Dr. Adi itu kan Dr. Adi itu pertama naikin PEP ya. PP-nya itu bisa tadi maksimumnya Dr. Adi bilang PP-nya bisa sampai 9. Saya nggak tahu lah tertinggi dokter sampai berapa, bisa sampai 10 apa emang 9. Itu bagaimana kita tahu dia, karena kalau hasil dari Dr. Adi nggak adanya kan tentang kematian, mortalitas, tentang BPD gitu dok ya. Tapi nggak ada tentang pneumotorak nih. Dari kejadian dari penelitian Dr. Adi itu pada saat kita naikin PEP-nya sampai kita tahu bahwa dia tidak akan mengalami desaturasi lagi, lalu kita turunkan, ada nggak yang kalau di atas sampai di atas 9 itu, walaupun di jurnal bisa ada yang sampai 10 dok ya, ada nggak yang terusnya jadi pneumotorak dok? Lalu apabila jadi pneumotorak itu diapain gitu? Apa di exclude? Apa terus langsung ada tindakan apa? Pertama mungkin pertanyaan untuk yang Dr. Adi tadi. Ya, untuk yang kedua tentang FOT ini. Itu tadi kalau saya lihat fotonya kan modenya harus HFO plus FOT ya. Apakah memang harus gitu pada saat kita melakukan FOT itu modenya adalah HFO plus FOT, atau boleh mode ventilator lain tapi yang ada FOT-nya gitu? Karena tadi ini kan contohnya selama HFO. Jadi tadi yang kedua juga fotonya ada HFO plus FOT. Nah, kalau dengan mode lain apakah FOT itu bisa dipakai atau tidak? Terima kasih.
I think the first answer will go to Mrs. Hui. My friend asked about FOT to another mode like conventional, because in this example this always about HFO. This HFO. She asked about that.
We can use it for conventional mode also. So you will see that here is for this one actually is for conventional mode. So we are using PEEP instead of mean airway pressure. So this is another case study. And if you use it on the ventilator itself, this mode we are on is actually IPPV. Okay, so we can actually use it to set the optimal PEEP for the patient. So instead of mean airway pressure settings, we are changing the PEEP for the patient, but it's also the same, like we go with in stepwise, where we go from 4, 6, 8, 10, then 10, 8, 6, 4. okay, to do the loop itself, the recruitment, the PEEP trial. So we can do in both high frequency as well as using it in conventional modes. Yeah.
Yes. Okay.
Is it correct?
Yeah.
Okay.
Maybe I will continue the question. Ms. Hui,
Yeah.
which one we should take the PEP for this case?
This
four?
one.
Four?
Yeah. So step number 4 here. So you can see that here the best reactance, which is the best compliance here, is at level PEEP 10 here. But then if you want to try more, okay, then we can actually increase the PEEP high here to 12. Okay, and see whether the compliance will drop down or not. So then, which means that at PEEP 12 we over distended.
Yep.
Then of course we will definitely know that 10 would then be the best.
Oke, jelas ya. Oke, mungkin pertanyaan tadi mungkin ditranslate bagi rekan-rekan yang ini. Jadi bisa ya dikerjakan pada ventilator konvensional. Bisa dikerjakan pada ventilator konvensional. Ventilator konvensional itu secara berkala setiap step akan mengeluarkan getaran HFO, tapi modenya konvensional dan keluarnya seperti ini. Yang di set tentu PEP, bukan mean airway pressure, tapi konsepnya sama karena PEP akan menciptakan mean airway pressure juga. Oke, pertanyaan ya Dr. Mahendra, mungkin saya jawab dulu pertanyaan takut lupa. Pneumotorak ya. Jadi saat kita lakukan lung recruitment tidak ada yang pneumotorak. Mengapa? Mungkin karena saat itu komplainnya masih pada buruk semua. Pneumotorak rata-rata terjadi setelah lakukan lung recruitment. Biasanya itu karena kita nggak cepat menurunkan setting mean airway pressure-nya, PEP-nya nggak turun, nggak lama diekstubasi dan sebagainya. Hasilnya nggak, cuman beda satu pneumotorak antara yang perlakuan sama yang kontrol. Lebih banyak perlakuan, kontrolnya banyak perlakuan satu ya. Jadi non signifikan, tapi bukan saat lakukan rekrutmen. 3 hari kemudian, 5 hari kemudian, rata-rata karena kita nggak cepat ekstubasi. Karena keputusan ekstubasi di tangan DPJP bukan di tangan saya. Saya coba merekrut. Ya silakan, Dr. Mai.
My question is, in which situations we recommend to starting use the FOT? Yeah, because as we know that if we increase the PEP, the hemodynamic also will change, especially the stroke volume will reduce, the hypotension will be happen because the cardiac output will get lower. In which situation that we recommend to use the FOT?
Yeah, so for FOT, right, it's based on what you think that you want to recruit the patient's lungs. So I think Dr. Adi did say that what type of patients that you will do recruitment for. So if you think that the patient's lungs is de-recruited and you want to do recruitment for the patient's lungs, you can do FOT. Yeah. Or alternatively would then be that not just recruitment itself, but also that if you have a patient, like just now we have a few examples, like if you give steroids, you want to see whether the lungs improve. You give bronchodilator, you want to see the lungs improve. Then you can also do a FOT to see whether the lungs compliance has improved or not. Yeah, so there are many applications that you can do on FOT, which happens at the bedside. So I cannot say that there is this patient you must do FOT. Yeah, but it's more towards that it can help you when you want to see certain things, but you don't want to do X-ray for the patient. Then it will be good that there is a FOT available for you to do this maneuver for you to check how good the patient's lungs are. It will be yes. So if it will be best if you can do FOT before and after. But then if you want, you can give surfactant, then you do FOT after to set the correct PEEP for the patient. Yeah, because doing before is more to let you see whether after surfactant it will improve or not. But then because you know that you are already giving, right? So it will be best to maybe just save time. You do after you give surfactant. Yeah, then after that you will be able to see how much PEEP you want to set for the patient and how much mean airway pressure you want to say for the patient. But if you are keen to do research case study, then you can do one before, then give surfactant and do one after. Yeah.
Ya, mungkin menyambung tadi pertanyaan Dr. Mahendra, belum ada yang terjawab tentang kekhawatiran untuk melakukan manuver rekrutmen paru akan mengganggu hemodinamika. Jadi sebenarnya ada data lagi di penelitian saya ya. Saya ngukur juga cardiac outputnya, ternyata yang dilakukan manuver rekrutmen paru, cardiac outputnya sama-sama meningkat, bagus, yang kontrol maupun yang direkrut. Dan ternyata cardiac output jauh lebih bagus yang direkrut. Jadi selama ini kekhawatiran kita dia akan mengganggu hemodinamik, ternyata tidak terbukti dari penelitian saya. Justru dia malah memperbaiki hemodinamik karena mungkin parunya makin open. Ada lagi penelitian lain juga ya, kalau nggak salah Nick Evans juga neliti. Ternyata memang ada yang dilakukan rekrutmen menurun sedikit cardiac output sebelah kiri, tapi angkanya statistiknya clinically not important, cuman beda 5 dari kan normal 150 sampai 300, dia cuman beda 5. Jadi nggak apa-apa dia bilang juga, itu juga sama. Gitu dok. Oke, kasih.
I have a question for you, Lam Hui Lin. How long that we can get the optimal PEEP or CDP based on the FOT?
When you mean by how long?
Yeah, because how long that the curve?
How long the curve will take? Is it?
Yeah.
Yeah. So, well, actually, because for us, the maximum number of time at each PEEP level is actually 3 minutes, but you can actually, once the patient reaches the mean airway pressure or the PEEP that you have set, you can start the FOT signal already. So it's actually maybe around 5 to 10 minutes. You will be able to finish the whole 7 steps. Yeah. But of course, if you think that the patient is unstable, the lung is more inhomogeneous, you want the patient to be on this PEEP level or mean airway pressure for a longer time before you do an assessment, then you can make it longer. So, but otherwise, the whole procedure, if you want to do it fast, around 5 to 10 minutes you can finish already. If the patient is quite stable, yeah, as in like you get very reproducible results, yeah.
So there is no strict times for that.
No strict time, yeah. So depends. Also, like maybe like what you have said, maybe the hemodynamics is not doing well, then maybe you will stop the procedure also. So, but generally, if the patient can do up to 7 steps and come back down with 1 loop, maybe around 5 to 10 minutes will be okay.
Okay, after we get the maximum CDP or PEEP for conventional mode, what next?
What next? So once you find the optimal mean airway pressure and CDP, you can go back to the settings and you set your mean airway pressure and the PEEP on that. And then from there, we will know that that is the point where we have the most best compliance for the patient. Yeah. Alternatively, is that you can do 1 more recruitment for the patient and then you set back the PEEP that you want for the patient. So you open up the patient's lungs already, and then you do you set the PEEP, the optimal PEEP and optimal mean airway pressure for the patient. Yeah, but this whole maneuver is actually recruitment. So once you are done with it, you can actually just set the value that you find it on there. Yeah, the machine will not automatically set for you. Yeah, so you will be the one to decide.
So we change.
Yeah, you
we change the such as in these patients.
Yeah.
So the optimum CDP is around 10. Is it right? 10.
This optimal PEEP is at 10.
Yeah. So how can we set the
we will need to go back.
We
we'll need to go back to the ventilator settings,
yes,
and then we will change. Yeah.
Oh, okay.
So this one maybe during hands-on we will show you how it looks like, and then once after that from there then we can do the settings change.
Because I will not in your hands-on. Because I have to teach another with volume guarantee during workshop.
Sure. Or during the later lunchtime or after this, I show you. Very fast, yeah.
Terima kasih. Tadi ada pertanyaan dari online ya, Dr. Andika. Dr. Adi, bisa nggak kita melakukan rang rekrutmen manuver manual dengan assist control tanpa volume garanti? Oke, pertanyaannya bagus ya dok. Kalau kita menggunakan kelebihan dari menggunakan volume garanti adalah dia bisa menurunkan tekanan puncak inspirasinya. Jadi ketika tekanan puncak inspirasi diturunkan, nanti delta pressure-nya turun, maka tidal volume akan tetap dijaga dengan pressure yang lebih rendah. Sekarang kalau kita gunakan, bisa sih kita lakukan dengan assist control tanpa volume garanti, cuman harus berhati-hati. Balik lagi ke konsep Laplace, begitu alveolarnya terbuka, maka pressure yang dibutuhkan akan lebih kecil. Kalau tidak diturunkan, maka nanti tidal volumenya akan besar. Itulah sebabnya resiko kalau kita menggunakan assist control, melakukan rekrutmen manual, nanti kalau tidak diturunkan PIP-nya, itu tidal volumenya akan besar sehingga bayinya menjadi hipokarbia. Nah, itu jadi yang saya amati ketika saya melakukan lung rekrutmen manuver dengan volume garanti, saya melihat penurunan PIP. Ketika saya melakukan rekrutmen menaikkan PEP misalkan dari 5, 5,4, 5,6, 5,8. Tekanan puncak inspirasi untuk mencapai tidal volume 5 mili per kilo atau 6 mili per kilo yang tadinya 30 bisa turun jadi 28, bisa turun jadi 27, bisa turun jadi 26, bahkan 25. Dengan cara seperti itu, safe bayinya. Silahkan dokter lakukan rekrutmen dengan assist control, namun dilihat VTE per kilonya. Begitu VTE per kilonya naik, dokter harus turunkan PIP secara manual. Jadi PEP-nya dinaikkan, PIP-nya diturunkan secara manual. PEP ngelihat saturasi oksigen, PIP dilihat lewat VTE per kilonya. Bisa secara teoritis, tapi lebih repot.